Hello everyone, my name is Gustavo Saposnik. I'm a stroke neurologist at the University of Toronto. I'm the chair of the scientific statement for the diagnosis and management of cerebral venous thrombosis from the American Heart Association. I would like to get started by thanking the American Heart Association and the subcommittee for commissioning this important statement. As you may be aware of, this is an update from our 2011 scientific statement for the management of cerebral venous thrombosis. And what I'm doing today is walk you through that manuscript and try to provide some highlights and the take-home messages. So to get started is, what is cerebral venous thrombosis? So cerebral venous thrombosis is a blockage, a clot in the cerebral venous system. And what happens when that occurs is that the drain of the blood from the brain is stuck and is blocked. So what happens is, usually on one hand occurs a cerebral venous ectasis, and then may occur a bleeding because of that venous hypertension, or maybe related with some other mechanisms, and that may lead to different symptoms. So how often does it happen? So cerebral venous thrombosis is only affect approximately 1% of all strokes, so it's a relatively rare condition. The problem is that it's not very well recognized, especially when patients present to the emergency department. So what are the most common conditions or risk factors for cerebral venous thrombosis? There are many, and I like to refer you to that table if you are interested in those particular risk factors. But what's different in this statement is that we identify some additional risk factors. So for example, what we know is that young women, those at the reproductive age, those in which they have a tendency to form clots for any reasons, one of the examples could be the use of oral contraceptives, they are more predisposed to have a cerebral venous thrombosis. Usually the most common clinical presentation is headaches. 95% of individuals with cerebral venous thrombosis may develop a headache, and I will explain a little bit more later. The second most common symptom could be seizures, and that's an important factor to be recognized. Finally, how do we make the diagnosis? So we usually need a combination of the clinical presentation, and initiate some investigations such as brain imaging, a CT scan or an MRI, and in particular venous images to demonstrate the occlusion of the venous system through the CT venogram or MR venogram. So how we make a diagnosis, or what are the key points that we highlight in this scientific statement? And I will divide into the evaluation and the management. In terms of the evaluation, as I mentioned, it requires a high level of suspicion. So a high level of suspicion is critical to be able to identify what is the next step. And the next step may be conducting, beyond the physical exam and the neurological exam, is trying to pursue some specific investigations, as I mentioned before, a CT venogram or MRI and MR venogram. That would be the ideal situation. So what the problem is that headaches and seizures may occur, and many people present to the emergency department with those symptoms and may not necessarily have a cerebral venous thrombosis. In fact, the most common reason for presenting to the emergency department with headaches is not cerebral venous thrombosis. However, if we miss that opportunity to make a diagnosis, those individuals may be discharged from the emergency department without the appropriate investigations, specifically investigation to identify a clot in the cerebral venous system. So I mentioned some new risk factors, so something that we have not identified before in 2011. One is obesity. So that has been one of the factors associated with cerebral venous thrombosis. And the other two important is COVID-19. With this pandemic, COVID has a virus, has a prothrombotic or generated prothrombotic state, And one of the factors is not only venous thromboembolism, but specifically also could be related with cerebral venous thrombosis. Finally, although rarely, vaccines, specifically adenovirus-related vaccines for COVID, has also been associated with cerebral venous thrombosis. In terms of brain imaging, the update, I would say that there are new sequences that are more likely to help us to make the diagnosis, specifically for conditions that may be very insidious, like cortical cerebral venous thrombosis. I'm talking about specific sequences of MRI that include contrast MRV or with gradient echo or SWI for, as I mentioned, for cortical cerebral venous thrombosis. Okay, let's move or shift gears towards the management of cerebral venous thrombosis. So as you know, anticoagulation is the mainstay of the management for cerebral venous thrombosis. The use of direct oral anticoagulants appear to be safe and effective, or an effective alternative options compared to what we used to prescribe before, and still for some patients are still receiving, for example. The strategy of identifying venous recanalization in subsequent cerebral venous venograms, or MRV, to guide the duration anticoagulation remains uncertain, despite this is being done in some of the institutions. Other strategies like decompressive craniectomy or surgery are only reserved as a life-saving procedure for selected patients with progressive neurological deterioration, and again, this has a low level of evidence. We also mentioned in the scientific statement about the advancements related with endovascular thrombectomy. Again, however, the level of evidence is relatively limited and also only reserved for those patients who had neurological and radiological progression despite the appropriate medical treatment. So I mentioned before, and it's important, that some vaccines, adenovirus-based COVID vaccines, could be rarely related or associated with cerebral venous thrombosis, and the underlying mechanisms is generating some thrombocytopenia, so low platelet count, and then it may generate a prothrombotic state. Finally, I'd like to highlight that this is important, the expert and multidisciplinary management, including hematologists and including the broad team that is usually part of any patient that we evaluate with the diagnosis of an ischemic stroke. We created an algorithm to identify or to facilitate the diagnosis and management of patients with cerebral venous thrombosis. Hope that this is helpful for any patients who you are seeing in any specific setting. What are the issues in terms of the scientific statements? I think that this is an important concept that you need to understand. Since this was commissioned, it happened almost 1 year since we conceptualized the outline until the publication of this scientific statement. So why this is happening and what are the factors associated with that? Well, again, it's important. The timing is one of the challenges for having, updated scientific statements. The second issue is the limited evidence that may be available or inconclusive evidence. Heterogeneity of the studies, so different designs, different populations, or done in different countries. Expert consensus in some situations in which the evidence is low and end up having expert opinion level for the evidence, or given the evidence. There is some practice variability depending on the country or populations or in different healthcare settings. And finally, most of the scientific statements don't count or don't rely also on having the opinion of patients or people with life experiences. And I think that this is important to take into consideration when we are analyzing or understanding the different scientific statements and guidelines. So what are the take-home messages? The important take-home messages is, in anything that we do in medicine, the first thing is identifying the problem. So where is the problem? What is the problem? Then We need to identify, once we make a diagnosis of cerebral venous thrombosis, then we need to identify what are the risk factors, what are the most important strategic interdiagnostic and interventions to be able to reverse the process of the cerebral venous thrombosis, and then to try to avoid complications. What are the core public messages or take-home messages? So for the public, it's important that they go to the nearest emergency department if they have a new onset of atypical or persistent headaches, a new onset of seizure, and some of the predisposing conditions that we mentioned, like being a young woman at the reproductive age, or during the perioperative, or taking oral contraceptives, or a tendency to form clots, and those including some younger people who may be exposed to severe dehydration. As a take-home messages for colleagues, remember, high level of suspicion is very important. Number two is, once you have a high level of suspicion, you have to order the appropriate test. Venous imaging, either as a CTV or an MR venogram, are critical. And finally, it's important that the treatment is started as soon as possible, and the appropriate treatment, is initiating anticoagulation therapy. I would like to thank very much to my co-authors and the whole writing committee who were instrumental to be able to provide this scientific statement and facilitate an algorithm for the diagnosis and management of cerebral venous thrombosis. Thank you very much for listening, and thank you again to the American Heart Association